Welcome everyone to today's webinar, Price Transparency, Clarifying the Unknown. I am Brian Zimmerman with Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. We will also have a series of audience polling questions during today's webinar. When we reach each poll slide, the poll question will pop up automatically on your screen. Our speakers will give a few seconds for you to select an answer from the options on your screen and click Submit. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. And at this time, it is now my pleasure to start things off by introducing our presenters. Randy Branter has over 18 years of healthcare experience in pharmacy, supply chain operations, hospital charge master, and finance. As HFRI's Vice President of Analytics, she is responsible for analytics among all areas of client hospitals, including marketing, market cost-based pricing, contract management, and reimbursement analytics. Ryan Rippert joined Para Healthcare Analytics in 2016 after receiving a BS in Applied and Computational Mathematics. He develops web-based solutions that meet price transparency guidelines and requirements while working one-on-one with the client to custom build the tool, ensure successful deployment, and manage future updates. At this time, I'm pleased to turn the floor over to Randy to begin today's presentation.
Thank you, Brian, and thank you to all of our attendees for joining us today and those who will be checking us out later on the recorded version of this. We look forward to clarifying the CMS requirements for price transparency. But first, a little about the sponsor for today's webinar, Para Healthcare Analytics, an HFRI company. HFRI is a leading insurance AR recovery and resolution provider that specializes in handling large volume, small balance, and age-problematic insurance accounts. At HFRI, we have developed an innovative aged insurance recovery solution using robotic processing and intelligent automation. In July 2019, HFRI purchased a revenue cycle consulting firm, Para Healthcare Analytics. Para has been partnering with hospitals and health systems across the country since 1985, supporting them with pricing, coding, reimbursement, and compliance. This partnership has allowed us to round out our offerings and move us towards our mission of becoming a comprehensive single-source solution for the hospital revenue cycle. Now, Para's services range from a web-based revenue cycle tool to a comprehensive revenue integrity program, complete with a charge master audit, pricing services, monthly department meetings, and ongoing pricing, coding, reimbursement, and compliance support. For today's webinar, we are combining our expertise to discuss how to address price transparency and some recommendations on how to meet CMS requirements for transparency. Today we will discuss price transparency, including background on the development of the requirements, interpretation of the requirements, a demonstration on how to implement the requirements, and pricing strategies to support transparency. We will conclude the webinar with a question and answer session. But first, let's get started with a couple of polling questions. When the screen prompts you, please answer the following questions. Does your facility have a price transparency tool currently? Yes, no, or uncertain? Now, this could be in the form of a charge listing, a cost estimator, through your state hospital resources, a variety of tools. All right, let's take a look at the results. Ooh, wow, so over 50% of you currently don't have a solution for this requirement. So as a reminder, a list of charges should already be live on your website as of January 1st, 2019. And the deadlines for the requirements we're going to discuss today is January 1st, 2021. So the clock is ticking. Second question. So if you do have a solution, what is your organization currently using to facilitate price transparency? and feel free to select any that apply. The list of charges on the website, a cost estimator, state website, not sure. Now, some of you in states like California or Colorado should have information available on your state websites already. All right, let's take a look at the results of this one. All right, good. I feel better about that. All right, so 80% of respondents have a list of charges on the website, which is great. All right, well, I'm glad you're here to learn more about how we can pull all of this together to meet our CMS requirements. So let's get started. Let's first talk about today's healthcare consumer in this brand new brand of consumerism in today's world, which has prompted the conversation around price transparency. We can classify today's healthcare consumer into the following 4 categories: the uninformed, the browser, the bargain hunter, and the informed. So starting at the top left, the uninformed are those who do not have the resources or know how to seek out those resources to compare hospital prices or understand his or her financial liability. These patients are a large part of a hospital's bad debt issue. Browsers. So these are those that perform web searches to compare prices, but really don't have a full understanding of how those prices impact them. So they're moving towards becoming informed, but really don't have a full picture of what it means to them. They usually do not contact the hospital directly for more information, or that information they receive from the hospital is lacking. Next are the bargain hunters. So these are those shoppers who know their insurance plans, their co-pays, deductibles, insurance, co-insurance. They may even have a doctor's order in hand. Now, these shoppers are looking for more customized quotes and will usually call multiple providers to get estimates. Finally, we have the informed, those who know their estimated financial liability, understand their payment options, and are ready to schedule services. As healthcare finance professionals, we want our patients to be as informed as possible in order to reduce bad debt and improve patient satisfaction issues. However, this all depends on our ability to provide that information in a consumer-friendly, intuitive manner. This process begins with us. Now, many hospitals have spent time, money, and energy on creating systems to arm their patients with transparent pricing information. However, others do not have the resources to support efforts such as these. It appears now we might not have much of a choice in the matter because CMS is involved and has established requirements surrounding price transparency. So now that we understand a little more about the healthcare consumer and have set the stage for the issue, let's take a look at some of the milestones surrounding CMS price transparency. CMS started introducing pricing transparency requirements way back in 2015, when it first required hospitals to provide a standard list of charges upon patient request. However, it wasn't until 2019 final rule that they began to require hospitals to publish standard charges in a frequently updated, machine-readable, online format, and not just upon request, but all of the time. The President's executive order in June 2019 promoted increased availability of meaningful pricing information for patients, the key word here being meaningful. So CMS's fiscal year 2020 proposed rule attempted to support this initiative by further defining those requirements. It requested payer-negotiated rates for charges and a separate list of shoppable services, including 230 hospital-selected and 70 CMS-selected services. The rule also outlined monitoring and enforcement, including a monetary penalty and corrective action plans from hospitals. Now, Ryan will dig into the specific details of each requirement in a few minutes, but I just want to point out that some states have been requiring a version of this rule for many years, with the exception of the payer-specific charges component. States' efforts to address the price billing issues has not gone unnoticed. For example, like I said earlier, states like California, Colorado, even North Carolina, among many others, have required annual posting of charge masters, a selection of hospital financial reports, and or a listing of common procedures for several years, demonstrating that states have been proactively addressing transparency for a while now. Other states are also beginning to require some form of price transparency in the coming year. As you can see in the timeline, the American Hospital Association opposed the CMS proposed rule as it was written. Their belief, and we agree, is that this approach would only further confuse patients in their search for information and would disrupt contract negotiations between payers and hospitals. We all know the current healthcare environment is riddled with various pressures in terms of handling thinning operating margins, health plan competition, and a shortage of internal resources, namely IT resources, to fulfill these requirements. Also, reimbursement methodologies and packaging rules are disrupting our ability to provide a true list of meaningful prices that would be actionable for patients. In June 2020, there was a summary judgment against the AHA, where a federal judge actually upheld the legality of CMS's rule, stating that it would allow patients to make pricing comparisons between hospitals. The AHA is obviously appealing this decision. However, this may become a moot point because on June 30th, a group of senators introduced the Healthcare Price Transparency Act. Now, the Healthcare Price Transparency Act was written to demand transparency through legislation. The group of Republican senators behind this legislation built from the president's executive order, as it would require hospitals and insurers to reveal cash prices and negotiated rates prior to the receipt of medical care. So, although we've been treating it as a CMS requirement, chances are good that it could become a federal law, which eliminates any chance of challenging the requirement in court. Additionally, the IPPS 2021 proposed rule is also discussing requirements related to disclosing payer-specific rates within the Medicare cost report. So CMS essentially is looking to see if using a median DRG payment rate from third-party payers or Medicare Advantage plans is a better methodology to allocate costs among the DRGs than the current cost-finding process. Now, we anticipate that this will lead to the use of this data to reduce DRG payments and possibly introduce lesser of language in this area. We will be interested to see what will eventually come of this discussion in the IPPS 2021 rules. So why do I say this? Based on all of this, we are moving forward with implementing price transparency solutions for our hospital clients and assisting in the data mining required to report this information to CMS. We as an organization have supported the idea of price transparency and true patient estimator tools for many years now. We are advocates of finding a solution that is capable of providing meaningful price information for patients and have worked to fulfill this need for many of our hospitals for many years. We believe that facilities must go the extra mile to ensure that the information we are providing to patients is useful and intuitive. While we don't agree with some of the components of the rule and find issue with how some of the information is being displayed, and Ryan will dig into this with some considerations on this later, we realize ultimately something of this nature will be implemented. So we're working with our clients to get them ahead of that curve. So what does this all mean? What are the requirements exactly, and what does it look like? For that, I'll hand it over to Ryan to talk about the specific requirements and strategies for meeting them.
Okay, great. Thank you, Randy, and hello to everyone. Now that we have an understanding as to where the requirements originated from respect to how the consumer shops for healthcare services, price transparency's history, and the current legislative ongoings, we will now step into the exact requirements CMS is mandating for the January 1st, 2021 deadline. The first of the two requirements hospitals must accomplish is the posting of the comprehensive machine-readable file. First, the document must contain each item and service that is available or performed at each facility. In other words, the entire charge description master, or CDM for short. CMS is requiring the identification of the following data points: the 5 standard charges for each listing in the entire CDM. First, the charge master price or gross charge associated with each line. Second, the self-pay or cash price, or a self-pay discount or other self-pay term is factored in to report the discounted cash price. Third, the negotiated price for each third-party payer, listing out the associated payer-specific negotiated charge for each insurance contract. Fourth, the lowest negotiated price of the third-party payers, presenting a de-identified minimum without specifically noting which contract is associated with this price. And fifth, the highest negotiated price of the third-party payers, similar to the de-identified minimum, but instead a de-identified maximum. Once we have collected all the necessary elements, this file must be published on each facility's public website where it can be easily accessible, without any intent to hide or limit access to the downloadable file. Furthermore, with respect to machine readable, the file must be formatted in a way that can be automatically read and processed by a computer. Some examples of acceptable file formats are Microsoft Excel, comma separated values, CSV, JavaScript object notation, JSON, or extensible markup language, XML. CMS is hoping that this first requirement furthers the development and usage of tools to create consumer and user-friendly price transparency solutions to stimulate competition among healthcare providers and, at the same time, lower costs. Now that we have collected all the necessary information for the comprehensive machine-readable file, let's look at an example of how the user would be presented with this related information. Here, we have a copy of a demonstration version of the machine-readable document to illustrate what CMS is looking for. Stepping through the document, we identify the first group. In this portion of the file, we include every item in the charge master, specifying the procedure or charge number and billing description, along with the first of those 5 standard charges, the gross charge or CDM price. We also identified the associated HCPCS or CPT codes and revenue codes for each listing. This first group was the basis of the Price Transparency 2019 requirement, where we must now build upon this to meet the new requirements. Moving on, we step into the second portion of the file, the mandated de-identified charges. We present the minimum, maximum, and the self-pay cash price to further ensure we include the required data points. In this last group, we include the remaining points, the negotiated price for each third-party payer. For this example, we have included just a small group of third-party payers, but to meet the requirement, we must list all of them and the related negotiated prices. With that, the single machine-readable document requirement will be satisfied once posted to a publicly accessible web page. When it comes to the consumer understanding the contents of this document, we must consider that there exist elements to the file that do not lend to effectively providing information. So with that, we acknowledge the consumer will be misled when identifying individual lines to obtain an estimate, contradicting the usefulness of the comprehensive machine-readable file itself. Each hospital must meet the requirement by posting the first document. However, the consumer does not receive a complete picture when attempting to obtain an estimate. If the consumer does so, they will only be receiving a price that is valued at the line level and not at the package level, thus providing impractical information. Understanding these considerations makes sense for why CMS introduced the second of the two requirements, the posting of the consumer-friendly shoppable services. And now with that, we step into how hospitals can meet that second requirement. Now, hospitals must also publish a secondary document along with the machine-readable file that lists 300 of what CMS has termed as shoppable services. Of these 300 items, 70 have been defined beforehand by CMS, where the remaining 230 are decided at the discretion of the hospital. If any of those 70 shoppable services are not available or performed by the hospital, CMS has stated that the hospital must state that those services are not available and to replace those with additional shoppable services at the discretion of the hospital. Similar data points must be identified for each shoppable service, as we did for the machine-readable document, the standard charges including payer-specific negotiated rates. Like the first requirement, this document must also be prominent and accessible for download on the facility's public website. Where this requirement differs from the first is that with each shoppable service, we must include any ancillary services that are customarily included by the hospital with the primary shoppable service. With respect to these ancillary services, we must take into consideration additional procedures, tests, supplies, drugs, etc., that are commonly performed with the shoppable service. We must also note additional professional fees that are billed separately from the facility, including the consumer, informing the consumer to expect an additional bill. With these required elements for the shoppable services taken into consideration, we see that this requirement does a better job of providing the user more meaningful information to continue towards their estimate. Now that we have an understanding for what is expected with respect to the listing of shoppable services, let's go ahead and step into a proposed solution. Now, in order to present a final document for the consumer to download, we must first gather all the related data for each of the 300 shoppable services. Here, we have presented a guideline that details some suggested steps in order to publish the second requirement. To start, we suggest to create an extract that first and foremost includes the 70 CMS shoppable services. At this point, we can now identify if any of those 70 are not performed at the hospital and take note to make sure we replace those services when considering the 230 additional items. Next, we must compile all the relevant data in order to decide which services to create the remaining 230 or more items. We suggest to include services that are of high volume, providing the consumer a listing of the most in-demand services being performed at the hospital. Once we have selected which services we will be publishing to the consumer-friendly listing, we must now pull in the ancillary services and professional fees that are customarily included with each shoppable service. In order to do so, PAR suggests using claims data to identify all related charges and create what we call a service package, meaning the shoppable service plus all related services and charges. With that, we can finally step into pulling the payer-specific negotiated charges, similarly to how we did with the first requirement. Now, in order to give further clarification as to which shoppable services should be included, let's discuss several service categories that we suggest to pull from. As each hospital attempts to identify the services that will comprise the final listing of shoppable services, we suggest to consider the following categories that you see now. Each of these categories gives the hospital a starting point to decide which services to include in the final listing of 230 or more items. Additionally, the suggested categories shown here were taken into account based on how often the services are performed at the hospital and the mandated 70 CMS shoppable services and COVID-19 testing. We realize that this process is complex, resulting in a burdensome task on the hospital staff in meeting these price transparency requirements. With that in mind, let's step into a couple examples we have assembled to show how the consumer will ultimately shop for these several services. Let's start with a few outpatient examples. First, a colonoscopy with biopsy. For this example, the service is one of the 70 mandated by CMS to include for each hospital. Stepping through, we pulled the primary service itself along with all the ancillary services and their respective standard charges, where we have created the package service as discussed earlier. Of those ancillary services, we see that there is an associated tissue examination and drugs that are being administered. Moving down, we identify the associated professional fees, and for this example, note that these charges will be billed separately from the hospital. Lastly, we pull in the payer-specific negotiated rates for the third-party payers, publishing the self-pay price, the de-identified minimum and maximum, and the payer-specific negotiated rates for each third-party payer. Now, let's consider another outpatient example, but instead of the shoppable service identified with the primary HCPCS or CPT code, let's look at one that is identified with an ICD-10 code. Here, we have identified a shoppable service that was selected by this demonstration hospital to include in the listing of 230 items. Specifically, an office visit by diagnosis, or the diagnosis is an other iron deficiency anemias. Similarly to how we presented the first example, we pull in that primary service and all related services and present the associated standard charges for the package. For this office visit, we identify ancillary services such as the complete blood count, venipuncture, several assays, and a hospital outpatient clinic visit, just to name a few. We next identify the professional fee for this office visit, charges related to an internist, like we did with the colonoscopy. Finally, we present the remaining standard charges for this package service. With these two examples we just shown, we show the complexity of a traditional colonoscopy versus an office visit, taking into consideration that identifying the ancillary services can result in a difficult task. Last, for the outpatient, let's consider what we think to be a simple service, an MRI with contrast. With this MRI with contrast, like we did with the colonoscopy and the office visit, we need to identify the ancillary services. When it comes to this particular MRI, we must note that there are additional items to include: the contrast, a routine venipuncture, and a serum assay. With this example, it shows the complexity of this process and the requirement to routinely pull this information together. Now, let's take a look at an inpatient shoppable service. This specific shoppable item has been identified as one of the 70 mandated by CMS to include for each hospital. Like the other examples, we have identified the ancillary services and their related standard charges, but now based on revenue codes customarily paired with this service. With these examples, we take note that CMS's intention to present to consumers useful information is more successful with this requirement. However, with producing this document, it requires the hospital to perform an extensive amount of processing to pull the related charge information. Okay, great. Now that we have discussed the two requirements by CMS in more detail, offered PAR's guidelines to meet those requirements, and presented examples as to what the hospital will ultimately publish, I will now pass it back to Randy to discuss further considerations and implications of price transparency. Now back to you, Randy.
Thanks, Ryan. And wow, the questions are totally coming in on those requirements. So thank you for that information, and we will get to those questions as soon as we can. But first, let's talk about preparing your charge master for price transparency. So the first phase of pricing transparency is related to preparing the charge master for publication. Before we can post charges, it's important that we have rational and strategic pricing methodology that the facility can support. I have another presentation solely devoted to pricing strategies, but for the purposes of today's call, I'll keep the concepts brief because I know we're really focused on the requirements. We recommend pricing charge masters according to the Medicare fee schedules, costs, or comparative peer pricing data. We also recommend identifying items that have negative patient satisfaction and price those items competitively for the outpatients against freestanding facility or clinic data. Now, hospital charges are divided into the basic revenue streams listed here. First, daily hospital services like observation and room rates. are used to represent all routine nursing and facility resources. Usually a study of capital, supplies, staffing, or other resources could be performed to determine a patient price for daily room charges. Although that does require some significant work, performing a capital study would help to ensure pricing is appropriate according to resource utilization. Hourly observation reimbursement differs by payer, such as case rates, percent of charge, and fee schedules. So we recommend these observation hourly charges be priced at 1/24th of the daily room rate charge. That's just so that 24 hours of observation is equal to that daily room rate. Second, emergency room and clinic charges, clinics like chemotherapy, wound care, hospital clinic services. Generally, we recommend pricing clinic levels at a multiple of reimbursement or at the peer group average according to the new or established patient designation and the acuity of the visit. Third are diagnostic and therapeutic services, common in areas like radiology, laboratory, and rehab. These procedures are usually assigned a specific CPT HCPCS code. As a rule, we recommend pricing at either a multiple of reimbursement or the average of the peer group pricing data. The exception to this rule, which I alluded to earlier, are items that are commonly have patient satisfaction issues. Common areas for price pressure include lab, CT, MRI, mammography, and rehab services. The outpatient price tier for these items should be priced competitively against other data sources, such as freestanding laboratory or radiology center averages. This just makes these charges more comfortable to communicate to patients shopping for these tests, thus allowing us to be more retail-oriented. Next are OR services, which are comprised of three components we'll discuss today: technical anesthesia, operating room levels, and recovery room charges. Technical anesthesia represents the hospital component of anesthesia administered during a procedure. We recommend creating charges based on the anesthesia time, where applicable, and that prices reflect resource utilization according to 6 types of anesthesia. Those types are general, MAC, and moderate sedation, which should be time-based. Meanwhile, epidurals, locals, and blocks are one-time charges. Operating room charges include the hospital component of OR services, including the setup, staffing, and any rental or special equipment associated with the procedure. Charges are recommended to be acuity and time-based according to staffing costs and any additional equipment charges. Now, this acuity leveling methodology allows the facility to account for the use of resources for a normal procedure. Meanwhile, the use of the additional time increments allows the facility to capture more complex cases and resource utilization. Therefore, again, we recommend pricing reflect resource utilization in those time-based increments. TACU, or recovery charges, that's our third component of OR services, are generally time-based with some instances of acuity or nurse-to-patient ratio considerations. So, for example, general anesthesia usually requires at least 1 hour of one-to-one care. Once the patient is attended to for that minimum period and the nurse assessment determines that patient can move to a lower staffing ratio, the nurse can then attend to 2 patients. Because of this, many facilities will create an initial 1-hour front-loaded charge with lower-priced additional 15-minute increments thereafter. We recommend pricing according to nurse facility resource utilization in this area as well. Finally, drugs and supplies. Now, drugs dispensed in a hospital setting can become a sensitive area for patients. This is just due to the patient's ability to compare prices against what they pay for their drugs at a local retail pharmacy. Therefore, the recommended practice is to create a cost-based markup with fixed add-ons and minimum charges to compensate for departmental resources involved in storing, handling, and preparing the items. Also, we recommend a separate markup for items considered self-administered. Now, like pharmacies, medical supplies are priced according to a cost-based markup as well. Now, many of you are shaking your head because lots of facilities fall away from maintaining the relationship between cost and patient price due to cumbersome update processes. For example, a facility may use an established markup to determine the initial price of an item, but in the years to follow, only apply an overall percent increase to all items. So as time goes on, items that were set up, let's say 10 years ago, will be drastically different than the items with similar costs set up more recently. Because of this, the industry is moving towards standardization of supplies to reestablish that relationship between cost and patient price across all supplies. This, in turn, addresses any potential compliance issues associated with inconsistent charging practices and price transparency, which we're talking about today. So again, we recommend using the actual cost basis to price supplies. We also recommend fixed add-ons or minimum charges that can compensate for those department resources for handling the supply, just like we see in the pharmacy area. Lastly, for supplies, we recommend creating a separate and distinct markup for the implantable revenue codes. So the 275, 276, and 278 revenue codes. Those are your lenses, pacemakers, and implants. Now, tackling each of these revenue stream areas to create a sound pricing methodology, again, is that first step in achieving our pricing transparency goals and improving the patient experience. Additionally, these pricing strategies allow for better contract management capabilities in that you have prices that are relative to the peer group market, and you can clearly articulate your pricing strategies to your payers and, more importantly, your patients. So with that in mind, I'll close this section just by saying that your organization, as it prepares for price transparency, should use rational pricing strategies that can stand up to the test of consumerism. So let's bring it all together. To be compliant with the first CMS requirement that Ryan outlined, the facility needs to create a machine-readable document that includes each of the data points Ryan outlined previously. For the second requirement, the facility must create a separate extract demonstrating the same data points for 300 specific services, including any ancillary charges that are normally associated with those procedures. CMS will deem a hospital as having met that second requirement if it maintains an internet-based price estimator tool that meets the following requirements. First, that it provides estimates for those 300 shoppable services, including the 70 specified by CMS. The remaining 230 should be identified using the techniques and data intelligence that Ryan outlined earlier. Second, that the tool allows healthcare consumers to, at the time they use it, obtain an estimate of their specific financial obligation for the shoppable service. And finally, that it is prominently displayed on the hospital's website, not hidden on some back page somewhere, and accessible to the public without charge and without having to register or establish a user account or password. Now, the screenshot on the right here is an example of PARA's price transparency tool, which has been implemented in many of our hospital clients nationwide. The solution fulfills all of the CMS requirements in a cost-effective, easy-to-implement, web-based program. Now, before we jump into our Q&A session, and like I said before, there are some excellent questions coming in. We have one last polling question for you. Now that we've shared how to operationalize CMS's requirements for price transparency, is your organization on target to be compliant with this requirement on January 1st? Now, surprisingly, we are seeing some of our larger organizations opt for that penalty to preserve the privacy of their negotiations with payers. So, all right, let's see. Ooh, very nice. Uncertain. All right, great information. Thank you so much for sharing. So if any of you would like to research any of this information further, we have included a list of resources for your convenience. This information includes the CMS presentation from an MLN, a fact sheet on the OPPS policy changes, a link to the CMS final rule on price transparency, a news release regarding the Healthcare Price Transparency Act that just came through on June 30th, and the IPPS proposed rule for 2021, which I alluded to earlier. As we continue to assign these questions and kind of wade through what's come in, I'd like to take a moment to share my contact information with you and to, of course, plug our product. As you can tell from our presentation, PARA has a handle on addressing price transparency with a variety of solutions to support your organization. Now, PARA's proposed solution to our clients is a process discussed previously that ensures rational pricing strategies, does the data mining to create that machine-readable document for CMS Requirement 1, creates the web-based system for patients that fulfills the CMS Requirement 2 for transparency. Our solution is completely customizable and mirrors the look and feel of your hospital's website. Our price transparency tool is easy and quickly implemented with minimal IT intervention. If you'd like to demo our solution, learn more about the pricing program, or if you're just shy and prefer to pose your questions one-on-one, feel free to give me a call or send me an email. We do appreciate your time and attention today and hope that we have provided some clarity on these CMS requirements. So we're going to open it up to the group. So this one came in pretty early. Ryan, if you can tackle this one. What qualifies as a hospital? There's a couple questions about rural health clinics. What can you tell us? Do those qualify? How do they need to report?
Yeah, of course. Okay, let me answer that question. I brought up the specific guidelines for CMS themselves, so let me just detail those. So with respect to the definition of a hospital, CMS has stated that a hospital is an institution in any state in which state or applicable local law provides for the licensing of hospitals, and then approved by that agency of such state or your locality responsible for licensing hospitals. So when it comes to that specific definition, it includes all Medicare enrolled institutions that are indeed licensed as hospitals, as well as any non-Medicare enrolled institutions that are licensed as a hospital. So making sure that that specific facility, or whether it be a rural healthcare clinic, or if you're questioning if your hospital needs to meet this definition, making sure that it is enrolled, that it is one of those enrolled institutions.
Perfect. Let's see. There are so many in here. On the listing of negotiated prices, is it by payer or the actual payer contract? For example, if you have 3 Blue Cross contracts, do you have to show each contract price?
Yeah, I can go ahead and take that question. So when it comes to showing all the payers, PARA's understanding is that we need to show each individual one. When it comes to, say, having a Blue Cross contracts with, say, a PPO, HMO, we do need to step in and present all those related points. When it comes to specifics about the regulation, it says negotiated rates need to be displayed. So any of those negotiated rates need to be included into this entire machine-readable document. In addition to talking about just what needs to be included, when it comes to Medicare and Medicaid rates being presented, we think at PARA that we need to include Medicare Advantage and also Medicaid replacement, but to not include traditional Medicare or Medicaid into that final posting.
Okay, so I think that kind of answers the question. There was another one that says, you only show the negotiated rates with the payers. What if you have various plans for each payer with different negotiated rates and reimbursement methodologies? How do you determine which negotiated rate to display? Again, that's our opinion to show them. Yeah, go ahead.
Yeah, so that goes back to if we do have that Blue Cross with different, say, PPO, HMOs, we need to show all that related information, those specific payer negotiated rates.
Okay. I'm just going to keep hammering these at you, Ryan. What about case rate pricing? How do you accomplish this in your organization? What about charges that are manually posted using a miscellaneous charge code?
I'm not certain about that. I think that's going to be something that we're going to have to do a little bit more research and then get back to you all about.
On the miscellaneous charge code. So, but our case rate pricing, we are looking at the Medicare data to determine what is normally charged within that case. So these miscellaneous ones, if they're onesies, twosies, that's not something we need to include in the extract. It's just something that would normally be associated with the procedure, correct?
Yes, that's my understanding.
Okay. So we'll do a little bit more research on that question and get back to you guys on that one. So I see another one that says, do you believe that CMS will move forward with the requirements? What will happen if we do not comply with the requirement? So I know I talked about this a bit earlier. We know there'll be a legal battle regarding the specifics of this rule. And the Senate's involvement is also creating a little bit more urgency for action. We realize that publishing payer negotiated rates will have a negative impact on our hospital's ability to really do business or negotiate contracts. We know that pulling all this information together is a huge ask of the hospitals. Again, negotiating those contracts, kind of cutting us at the knees. Some are calling it a race to the bottom. Who's going to get that lowest rate? What's going to happen to hospital reimbursement? Also, you know, publishing these rates without context really doesn't move us to a better place than we are currently with publishing the standard charge master rates. But we support finding a solution that's capable of providing meaningful detail for patients. The second question, what will happen if we don't comply? The rule states that the hospital will be penalized $300 per day. So, you know, a little bit over $100,000 a year. For some organizations, it might be worth paying the penalty, but there's also a statement regarding the corrective action plans, which is a little ominous. Although we haven't really seen the details, we do anticipate that the ultimate penalty may be a loss of provider status with Medicare and Medicaid. So we are looking at that. Let's see, what else do we have? Some of these, Ryan, do you see? There's so many. Someone's asking if we have a standalone price estimator. Yes, we showed that on the screen. If you'd like to see a demo or anything like that, we can definitely pull that, you know, set that up for you.
I do see a question that we can answer quick off right here. How do we ensure we hit the exact requirement for the deadline? I can go ahead and take that.
Perfect.
So to answer the question, the requirements mandate the publication of the two documents to a publicly accessible website or web page. First, a listing of services and items at the hospital, along with those standard charges, as we discussed earlier. And then second, the listing of shoppable services with all of those corresponding charges. In order to take it further, we need to make sure that each hospital complies with CMS requirements. The data must at least be updated annually, where we must clearly note the specific date the documents were last updated. By publishing these two separate documents and making sure to routinely update them and all the associated information, we are intending to make sure that each hospital has met the exact requirements for that 2021 deadline.
Perfect. I have a question about decreasing prices. So how do you address reducing prices to make them more shoppable if you have lesser of charge provisions in your contracts? For those of you who may not know, some managed care contracts include lesser of language, which limits that DRG and HCPCS reimbursement or case rate reimbursement to either a published fee schedule amount or the billed charge, whichever is less. So many times, if a hospital does decide to reduce prices, it may inadvertently cut reimbursement at the knees, right? So when we're working with hospitals, we must first determine what the average of the group is to kind of gauge where we are pricing transparency-wise, and then adjust that proposed price according to the managed care contract restraints. Now, since more patients are shopping for these services, our recommendation is to ensure that the hospital prices are first in line with the average of that selected peer group, and then determine if we need to make adjustments and confirm that that price is above those fee schedules to ensure maximum reimbursement at that line item level. If you provide a solution for online price estimator, is it for all services or for the 300 determined shoppable services? So from our perspective, our solution is very customizable. So Ryan, you can jump in if you want. Our solution is very customizable. We can either cover all services or just a few that you select to share. And is there anything you want to add to that?
Let me add on to that, a little bit. Like Randy was discussing in probably one of the last, or towards the end of her presentation, we can use that estimator to replace that second requirement, the 300 shoppable services. So in order to use that price estimator to replace, we do need to load in those 300 shoppable services. But when it comes to PAR's exact solution, we can step back past those 300 shoppable services and include any other additional items, services that you all would like to include into that specific price estimator.
Perfect. There are so many. They just keep coming in. Okay. What is to stop a payer to compare shop and state that they will only pay what others pay? I was kind of talking about that earlier. You know, we know that there's a lot of issues with this. We take a lot of issue with how this is best illustrated to our patients, right? Right now, the rule as it's written isn't meaningful, it isn't useful, and it does open up hospitals to that sort of data mining by payers. We are really hoping that with the Senate's intervention, they can create something that's more intuitive, like a price estimator tool that doesn't exactly publish the rates, but it still gives that individualized information to the patient. Ryan, do you have anything you'd like to add to that?
No, I think you nailed it, yeah.
Okay. Is it part of the requirement to check patient ability and quote true out-of-pocket, such as patient copay and deductibles? Ryan, I'll let you take that one.
Yes, so with respect to pulling in copay and deductibles, when it comes to the requirement, they're not asking to include those to get that true out-of-pocket cost estimate. When it comes to a price estimator solution, factor those points in to present that true out-of-pocket cost estimate back to a consumer coming.
Okay. If we use a price estimator, does it need to include all contracts or just our top 5 or so? It does need to include all payers. Right, Ryan?
Exactly. So very similar to that published document for the second requirement, we would need to list all payer rates and then also all of those standard charges, those 5 standard charges, the gross charge, the de-identified minimum, that de-identified maximum, the self-pay rate, and then stepping into all of the negotiated rates as well.
Okay. how do you indicate prices if a Medicare or Medicaid Advantage plan pays 100% of Medicare, Medicaid, and pay versus APG or APR, APRG or APG? We've got a typo here, I think. So Ryan, how do we handle Medicare Advantage, Medicaid Advantage plans in the tool, in our requirements?
Yeah, with that, I would need to do a little bit more research too to see specifically how we're handling them.
Perfect.
So we will get back to you with our answer.
Yeah, I've noted that. All right, is there any others, Ryan, that you think you can tackle real quick, or are we going to have to follow up with others? We're short on time. Oh, here's one. Are there any additional requirements imposed at the state level that you're aware of?
Yeah, okay, great. I can go ahead and handle that question. So yeah, when it does come to those additional requirements, we do see that some states have gone beyond the CMS mandates to include state-specific guidelines when dealing with price transparency. For example, the state of Indiana has recently passed legislation for hospitals to produce a good faith estimate within 5 days of a service or services being scheduled. This good faith estimate details the specific prices associated with non-emergency healthcare service or services that are charged directly by the facility. The state of Indiana is also requiring hospitals to prohibit what they term surprise billing, notifying the consumer or patient specific details about out-of-network petitioners and also in-network facilities intending to charge more than allowed per the rate established by the coverage plan. So yeah, transparency has gone past to just those requirements at the national level, but also may be required for hospitals to follow at state-specific guidelines. In order to figure out or to determine if you all need to meet any specific state guidelines, PAR suggests to connect with your state's hospital association to determine if there are any additional requirements that you do need to meet at the state level.
Perfect. All right. Brian, anything?
No,
yeah.
Okay.
Well,
so we'd like
Randy,
to thank
Ryan,
everyone again. Go ahead, Brian.
No, sorry. I just wanted to thank you both for that great presentation and tackling all those questions for our attendees today. And if you had any final thoughts or anything you'd like to leave attendees with, Randy or Ryan.
Yeah, I was actually just going to say, we'd really like to thank everyone for their attention. We want you to know that we understand the complexities and the challenges and the ongoing questions of meeting these requirements. It won't be easy, but it will eventually be the right thing to do for our patients once we can navigate around some of the issues we're seeing, and as long as we approach it the right way. So I want to thank everyone again. Please take care and stay safe. Ryan, anything to add?
No, I just want to thank everybody again, and then to have a great day.
Thank you both once again. It was a great presentation. We had tons of great audience engagement. It was really wonderful. And I also just want to thank Healthcare Financial Resources and Para Healthcare Analytics for sponsoring today's webinar. Enjoy the rest of your day, everyone. We look forward to having you join us for future webinars.